It's always look at the audience. But I'm more guilty because we invite her to speak at our mission retreat. Oh, great! And so she's really got on to develop around patient physician engagement. And
So I sat last year's planning session last week. The agitation of the session. Something's happening. Also, I was very
Right. Minus $2 million, similar.
Yes, I saw this.
yeah, and it's like
So we're hoping this things like this. Your memory is
Really fast.
Hey, that's too frustrating. How far? It's over by the end of the. Huh? I can tweet. Huh? You people are. This is just any click. It goes ahead. Oh, I can use this. Yeah. No, I'm fine. Yeah. Also make sure I had all my stuff. Need my water. Where should I put it so I don't spill it? Maybe put it over. Okay.
First slide of the technology and health.
Good morning, everyone. Good morning. Good morning, everyone. Why don't we try to get started so we can get through our great program today. Good morning and welcome to the Connecticut Health Council program. This is our first program at the Yale School of Management, and we're so thrilled to be here. We're very fortunate to be able to utilize this beautiful facility and hear from some of our leading experts in healthcare from the state of Connecticut. I'm Amy Cunningham. I'm the Executive Director of the Connecticut Health Council. And we always like to start off all our meetings by communicating what our mission is of the Connecticut Health Council, and that is to promote Connecticut as a center of health excellence. I would like to also recognize our sponsors for today's program. First, CareCentric. We truly appreciate your sponsorship and your participation in the planning of this program. Also, we would like to thank our media sponsors, the Hartford Courant and Fox CT. And of course, again, I would like to thank the Yale School of Management for allowing us to use this facility. One thing I want to mention, at the conclusion of Dr. Krumholz's presentation and our panel discussion, we will have a Q&A session. You have noticed that there's microphones in front of all of you. If you would like to answer a question or ask a question, please just press a button, a little green light will come on, and you can then proceed with your question. We ask you to proceed in this method because this entire program is being taped. Also, at the conclusion of this program, we will be providing tours. So if you would like to have a tour of this beautiful facility, just stay in the room and we will arrange that. And I also want to comment and thank our founding partners of the Connecticut Health Council. The council continues to grow, and without your support, we couldn't be here today and continue to succeed. Now I would like to introduce Christina Minelli. Christina is the General Manager of Care Coordination Solutions for CareCentric. Christina will be introducing Dr. Krumholz.
Thank you. Good morning. Good morning, everyone. I'm thrilled to be able to be in this facility, too. I never got to use it as a student because it was built after I graduated, so I get to come here now at the Connecticut Health Council, which is great. I'm very pleased to introduce Harlan today. Harlan Krumholz is a cardiologist, healthcare scientist, and healthcare improvement expert. He's also the Harold H. Hines Jr. Professor of Medicine at Yale University. He's director of the Yale-New Haven Hospital Center for Outcomes Research and Evaluation and co-director of the Robert Wood Johnson Foundation Clinical Scholars Program at Yale. Dr. Krumholz has published more than 800 academic papers, and his research focuses on improving the quality and outcomes of clinical decisions and healthcare delivery, eliminating disparities, and avoiding wasteful practices. Dr. Krumholz also initiated the formation of collaborative efforts at Yale, where he worked with applied mathematicians, statisticians, computer scientists, biologists, informaticists, and outcomes researchers to define advanced methods for using high-dimensional data to solve clinical and healthcare research problems in medicine. He received a BS from Yale, an MD from Harvard Medical School, and a master's in health policy and management from the Harvard University School of Public Health. I'm happy to see he's wearing blue instead of crimson today, so I think that was a very good choice. In addition to his very impressive bio, I can personally tell you that he is a very engaging and thought-provoking speaker, and he's very passionate regarding the topic of patient data and how it can contribute to improved outcomes and an improved patient experience. Welcome, Harlan.
Thank you. That was terrific introduction. Well, thank you very much. It's a great pleasure to be here with you today. Yes, I'm a faculty member at the School of Medicine, and I have the privilege of working with the hospital and healthcare system as the director of the Center for Outcomes Research and Evaluation, and have a wide variety of roles. But today I'm just a person who's coming to you with a big idea. I want to share with you a big idea and see what you think. And I think this idea can transform medicine. And I say that humbly and with a little bit of uncertainty about how it will play out, but I think all great things start with big ideas. And the question is whether or not this idea will really make a difference. You're a very diverse audience. You're smart, you're talented, many of you experts in healthcare. I'm also asking you to come here today thinking about your role as people, as individuals, as people who depend on the healthcare system to do well, people who need it to perform extraordinarily well, who need it to be available when you need it, and people who need it to be affordable, both for yourselves and for its impact on society. And I want you to think about that not just for yourselves, but for your families and friends when you're pulled into situations where it's vital for these things to be occurring. And how you need a healthcare system that can learn, every day learn, so that tomorrow it's in a better position than it is today to help you and the people that you care about. And this is the premise of this big idea. And the big idea is, okay, I'm going to give you some context first before I give you the big idea. So, this is what you're going to hear. So, medicine's on the cusp of remarkable change. And it's actually very interesting. I think we're on the cusp of a next major revolution. So it began as a priesthood, right? I mean, there were certain people who were sort of imbued with the power over disease, knowledge, even though that knowledge seemed to come from who knows where, the ether. There was suppositions about how the body worked and how disease worked, but it was a priesthood. And then medicine made its big leap next as it became a science. And we began to invest in our understanding of the mechanisms of disease. We began to understand how we could target disease, how we could prevent it, how we could understand it. The diagnostic exercise was about classifying disease in certain ways so we could understand, because of what we were labeling this, we could begin to understand how we might be able to prevent it in the first place, or how we might be able to treat it to mitigate its impact in the second place. So we began to develop effective preventive diagnostic and treatment strategies. These grew over the last century to remarkable success. And what's really happened has been breathtaking. We've gone from a life expectancy in the mid-40s in this country, for example, up into the 80s now. And for all of our concern about health and healthcare, behaviors and so forth, there's just been remarkable gains. Next week, there'll be a paper that our group put out that's going to appear in JAMA, which will document some of the changes over the last 15 years in just among Medicare beneficiaries. And you'll see described remarkable decreases in hospitalization rates, remarkable improvements among the smaller group of people who are being hospitalized in their hospital outcomes. You'll even see at the end of life how people are spending fewer days in the hospital. So in many ways, despite our singular focus on the problems and trying to make sure things get better, things are getting better. And in fact, this investment is paying off. My life's work has been focused on improving healthcare, making it more likely that people get the care that they need and the outcomes that they desire, aligned with their preferences and values and what their goals are with regard to the healthcare. The themes of my work have been the identification of these opportunities to improve through rigorous measurement of our performance. Then, not just about describing these problems, but I've been working with others, and there are large numbers of people across the country, to achieve improvement through a focus on better teamwork and engineering better, highly effective, reliable systems so that we can know time after time we're going to get extraordinarily good results. We've also, if you look at what I've been doing, I've been promoting transparency as a means to catalyze change, as a way for us to be accountable and honest about what we're achieving in our science and in our healthcare performance, both, because we've historically not necessarily been revealing about either of those areas, and we can do a lot better. And then finally, if you look for a theme in the work, it's the advancement of patients at the center of everything, pushing the idea that everyone in the healthcare enterprise needs to see through the eyes of patients, needs to understand their experience, needs to think not as healthcare professionals working on throughput or revenue or trying to understand results from our perspective, but we need to be able to understand from them and then configure the system to ease their path and help them do as well as possible, given their circumstances and given our abilities and capacity. We collectively, my group and groups around the country, have had some success, as I mentioned. In cardiology in particular, we've spent the last few decades really singularly focusing on whether or not we've made the most with the knowledge that has already been produced. Our first wave of this was to discover rather shameless variation in care. Many missed opportunities to employ effective treatments, long delays in emergency treatment, and remarkable variation that now is, I think, very well understood by every person in this country, remarkable variation in the outcomes that are being achieved. The influence of the place you went on your outcome was almost as profound as the actual condition you had when you showed up. The spread of outcomes, survival, among the hospitals in this country were as large as some of the risk factors that you might have in coming into the hospital, meaning that the hospital itself could be a powerful promoter of a good outcome, could also be a contributor to an unfortunate outcome, in the same way that many of the characteristics of the people themselves might have. And so we began to work on that with at that time, the peer review organizations, quality improvement organizations. I don't think the CEO from Qualidime said he couldn't make it today, but Qualidime in this state, which was a Connecticut peer review organization when I first started working with them, began collaboratively working with hospitals. Hospitals stood up to the challenge. Doctors and nurses and healthcare professionals And they said, yeah, this isn't right. This isn't right that only half the people among those who are ideal for a particular therapy in emergency care were receiving it. When we first started this aspirin, a very simple, cheap, inexpensive medication that could reduce the chance of mortality by 20% for someone suffering a heart attack, was only being given 2/3 of the time. Some parts of the country, only 1/3. Beta blockers, similarly. Through collaborative efforts, we were able to improve the use of these highly effective medications. In addition, we were looking at delays. It was sometimes taking 3 hours for people to be treated for emergency angioplasty, opening a blockage for a patient coming in with a heart attack. This is in the 1990s. We were able to get NIH grants, study this, do mixed method studies, interview people, do large national surveys, work collaboratively with 1,200 hospitals. And ones like Yale-New Haven Hospital begin now to routinely treat people within an hour, some people within 15 minutes. So these kind of changes in the systems, this kind of orientation, extracting better performance out of this, actually just not with any new article that said, by the way, if someone's in an emergency, it'd be good to treat them quickly. Nobody wrote that article. We already knew. Yeah. So it was a matter of saying, okay, how do we do this? How do we get it done? And just to give you an example, this is this new idea, but this is an example of an article we published looking at heart attacks and unstable angina, almost about heart attacks. And on the left-hand panels, what you're seeing is the spread of variation. This is hospitalization rates across the country for these conditions. Green's good. Those are the lower rates. These are the same scale for the 2 years. You see what it looked like in 1999 with a lot of hot spots. By the time we got over to 2011, and it continues to improve, the whole nation is just about at the level of the very best regions were in 1999. We see almost a 40% reduction over the period of time, and it's nothing short of jaw-dropping in terms of what's been accomplished. Now, the underlying cause, it's hard to unravel. Hospitals, healthcare, behaviors, policies, it's a whole range of different things. But at the end of the day, this is what we got to be accountable for. What are the results that are being achieved? And this is showing you some of this work. The results of it in cardiology, we're very, very proud of it. So, seems like things are going pretty well. I think we can congratulate ourselves quite a lot. Maybe we should just go home. And, quality in healthcare is now becoming part of the lingo. When we first started this, we were kind of on the JV. We were on the side talking about this. We couldn't quite get it on the varsity team. The varsity players were, up front and center, but they wouldn't, this idea of being accountable, rigorously and systematically collecting information, talking about teams but not stars, talking about the way people are going to work together, being accountable for what the patient experiences as the outcome, not just our piece of it, but whether or not at the end of the day the patient was in better shape and was highly satisfied and getting good. All these things were not necessarily welcome. They certainly weren't commonplace. Someone like Gail Capozala was talking a lot about this when she came. She'd been working with Institute for Healthcare Improvement. There have been a lot of, but these were still at the fringes. Now it's mainstream. In addition, I can tell you that the next generation basic science looks very, very promising, the kind of things that are going to come around. The speed with which we can sequence the genome, the ways in which we've been able to improve our approach to problems, the big data issues that I'm working on with many of the scientists here at Yale, where we're now going to be able to take highly complex, high-dimensional data and not strip it of its richness so we can do our traditional regression analyses, but begin to employ more advanced approaches so that we can maintain its complexity and learn from it. I think all these things are going to bring about remarkable change even in the next 10 years. And yet, I say this and yet, problems still abound. I could show you that map where everything's green and say we've moved downward, but there's still a lot of variation in the country. There's still places that are doing better than others. So we're improving, the curve shifts, but there's still opportunities for improvement. The cost of healthcare may be actually one of our #1 problems. Not only is it draining resources from individuals and from institutions and businesses, but also from municipalities, governments. We are unable to invest in the areas that we need to invest in this country because such a large percentage of our GNP is being spent on healthcare. Now, a lot of that, by the way, is good investment. We're getting good return. There are high-quality jobs that are being generated. There's good work that's being done. but we all know there's still also a lot of waste. There's a lot of inefficiency in the system. There's ways in which some of those dollars could be spent better. There's ways that could make our society stronger. There's ways that could minimize the individual burden on people for whom the out-of-pocket costs still remain prohibitive. So the costs remain a big issue. And then we still have an issue of not providing, I think, enough opportunity for people to make the right choices about their care. That we're still practicing a very paternalistic system that goes top-down. We're not creating enough shared decision-making opportunities. People still don't know enough about their options. We're not creating the kind of platforms where there's a real partnership in care. And then finally, I don't think we're generating knowledge fast enough. As someone who does spend some of my time generating new knowledge, trying to provide the basis for what's going to be next, I can tell you we're going far too slow. It's too expensive, it's too slow, and it's too off-point too often, where the papers get published, but they're not feeding directly in ways that they can actually make improvements and be practically important to the lives of people who are receiving care or waiting for improvements in the way in which their health is going to be affected by the kind of care that's going to be delivered. So we've got to rethink this whole enterprise because it's the needs of the patients far outstrip the speed with which we're generating the knowledge to help them. And you can only look at any guidelines we produce. There's studies of them that show that maybe only 20% of the recommendations within most of our guidelines are based on evidence. And the other 80% are just expert opinion, which means a bunch of people sitting in a room thinking, I think this is probably the right thing to do. And there's reasonable disagreement within that. So, I know, I remember there was this big idea. So, as I started to reflect on my experience as a doctor and my experience with patients that way, and as someone, as a person who's helped friends and family who were ill, and sometimes as a patient, which I've been at times, and as a researcher, I started to have a sense that there was a really big problem that we weren't addressing. That was a fundamental block to the kind of rapid advance that we're trying to make. That's keeping us from making it to the next generation of medicine through this next revolution. So medicine's evolving, I think. I would assert this strongly, to be an information science. So the technical skills are always going to remain important, right? The hand motor skills around certain procedures, those will be important. The humanistic skills, probably even more important in a highly technological environment of medicine in the future. So those things go without saying. They're pillars of medicine. But the major middle part of medicine as it's evolving is its ability to transact, understand, manage, communicate, and leverage information. The information that's growing every day, that has the possibility of drowning us, but yet inside it has the potential for insights and opportunities and knowledge that can truly inform choices and get us to a better place in healthcare. So I think that this is the next big change in medicine, this transition to an information profession in science and enterprise, or at least it could be and should be. And yet, when I look all around, and this is getting to what the problem is, I see a profession, I see an enterprise that's anchored firmly in the past, especially with regard to data, and that's a threat to each individual and to the progress that could be made on behalf of that person in the next generation. What do I mean? Well, when I was trained as a doctor, most information was still on paper. And what you could do with it was quite limited. People's records were scattered all over the place, wherever they'd seen care. And you rarely had all the information where you needed. You were always missing data. People themselves had poor access to their own records. They couldn't move them around easily. It could be expensive to get a copy of your records. Researchers with people's permission had to manually extract information from paper records or that they were able to obtain from other sources in order to collate the information about individual patients. It was a slow, arduous, and inefficient process. And now, what's the story now? Well, we have digital health data. In most places in the country, the data exists in digital format and reside on computer systems. But, see if this sounds familiar. People's records are scattered. They rarely have all the information they need. People have poor access to their records. They can't move them around easily. It can be expensive to get copies. Researchers with people's permission have to manually extract information from the charts and find a way to analyze it. It is a slow, arduous, inefficient process. We have moved the data from analog to digital without changing anything else about the way the system is configured. We're left with a system that's 1950s in every respect, except the data are digital and we're working on terminals. In most other respects, when I was rounding last week, I think it would not be unfamiliar to Dr. Kildare or, I don't know, Marcus Welby or anybody who was rounding from the era in the 1950s would feel very comfortable, except that we're pushing around computers and looking into terminals. But in the way that we do the work, in the way the data are scattered, in the way it's organized, in the way we're leveraging it, we still have this very big mindset that it's paper. We can't move from that paradigm. And so there's no area in our lives where information is more important than healthcare, and yet we remain tethered to the past. Yeah, there are a few bright spots. Some of you may be pioneers of some of those bright spots. I'm not suggesting that they're not, but largely this is the case. And I started to realize that unlocking the value of healthcare data, turning it into useful information for people in society would be imperative for us to move medicine to this next phase. So how can I put this in context? I thought, well, okay, how about Amazon versus healthcare? I go on Amazon and they know who I am. I go to the doctor and I have to fill out information forms and tell them who I am. Every time almost. I go to Amazon, they have my complete history. I go to the doctor, I meet someone new, I've got to keep telling the story over and over and over again. I go to Amazon and they give me personalized suggestions. I go to the doctor and they talk about studies that are relevant to the average person who enrolled, someone who's nothing like me, and they tell me that because they did this study that I need to be stuck with what the average results are for a large number of people. That's like going on Amazon and telling them, they telling you, you know, I think you probably want to buy shoes today because more people bought shoes than anything else today, and probably that's what you want. Doesn't make any sense. I go to the doctor and I'm often told what to do. I go to Amazon and they combine information about my past and present, honoring my individual preferences and quirks, and allow me to make a choice. I leave Amazon site and I'm usually satisfied. I leave the doctor and this isn't about the doctor, it's about the systems. I'm often frustrated. And so, by the way, there are ways Amazon doctors and health systems are similar. I can't move my data from Amazon. I can't share the data. I can't use it elsewhere. I don't know what the data say. I actually can do some of those things with my medical data, but it's not easy. But, you know, so I'm not saying that everybody's allowing free-flowing data, but there are ways in which they are more attuned, using more advanced analytics, and their front end is much better. So I'm back to the big idea. I say we need a solution to the fragmented nature of healthcare data, the challenges in bringing them together, and their inaccessibility to patients. Let me say that again. Fragmented nature, difficulty in bringing it together, the interoperability issue, and its inaccessibility to patients, which means its lack of usability to patients if they can't even access it easily and inexpensively. So it's like this. The big idea, people need to control their own healthcare data. Simple, clear. People need to control their own healthcare data. People need to control their own healthcare data. So this is not necessarily a new idea, right? Because the idea of personal health records has been around for decades. Other people have tried to solve this. Even Google and Microsoft with their deep pockets and extensive expertise in information science. But I say there were a lot of things. One is I think their timing was off. They were early. They were there before electronic health records had actually spread across the country through the kind of legal promotion that had occurred through the Affordable Care Act and through meaningful use statutes. So they were a little bit early. There were no incentives for health systems to participate really at that time. Who was going to pay for it? What was the business model? Who was going to benefit? There was no wind behind their backs with regard to that push and momentum, and there was no large-scale clamor for it from the public. But now the electronic health records are ubiquitous. There's strong regulatory requirements that are not only telling people you have a legal right to your records, but are providing financial incentives for hospitals to engage people with their medical records. And in addition, you may have heard this loud, determined, growing public movement around people. Data liberación, they're saying, get my data. Look up hashtag, get my data. They're saying, request your data. It's your right. You should get it. The NIH director tweeted, I'm going to go get my data. On board, Farzad Mostashari, a Yale Med School graduate, former head of the Office of the National Coordinator, is helping to lead this effort to say, we need to be able to get people records in their hands. But there's no mechanism. That's the issue. What's the mechanism? That's the problem. So let me talk about what is and what could be. What is? Patients have a right to the records, but in most cases have to pay for them. It can be quite expensive, even though it's just about moving electrons. Data exist in structured and computable forms, meaning they can be used in many different ways, but when they're requested by patients, they're taken backwards into non-computable and unstructured ways. We give them paper and PDFs instead of fields, and we lose information in giving it to them, and we make it difficult to get actually the real information, like images or actual tests. We make it, if anything, are going to give them reports, seen through the interpretive eye of other people. Sharing data with others is often difficult, and it could be different. Patients actually could have all of the records available to them whenever and wherever they need, for whatever purpose they choose. They could be securely available, like online banking. They could have everything, all the details, organized for easy use, see it, search it, and share it. When they're on vacation, no matter where they are in the world, it could be available to them if they needed it. If they wanted a second opinion, they could get one seamlessly. If they wanted to form a community of people with similar issues, they could do it. If they wanted to move it, if they wanted to become data donors, anything, it would be theirs. All of a sudden, it would change the entire approach. The market would need to respond now. You've got now people who've got something of value and want to do something with it. The market can respond in ways. You wouldn't just depend on government to do it. How about clinicians? Clinicians now are faced with missing information. I was in the hospital rounding over the last 2 weeks. There wasn't a single patient. It's okay. These are going to go up one at a time until my talk's almost over. And then a big hole forms right here. So you'll see. It's one of those game shows to see if I can finish. I'll be watching. So there wasn't a patient I saw who didn't have some data missing somewhere. And we were trying to pull together. Now, in the more extreme case, a guy came in with chest pain. He was from Florida, visiting his family. And we were trying to determine whether his electrocardiogram had changed. And, actually we were very lucky because it only took us 6 hours to get a hold of his doctor in Florida. And their office was during the week, and we made the transaction. We were able to prove that he was in there, and we were able to get by all the HIPAA issues. And then they faxed us his electrocardiogram. Let me just say that again. They faxed us his electrocardiogram. And now our black and white fax machine on the floor of the hospital takes an electrocardiogram, which has, you may have seen these, light pink background and sort of dark tracings on top of it. All cardiologists are sort of used to this standard way of seeing it. And the reason it's done is because of the nice contrast between the tracing and the background. I'm here to tell you, when it comes out in black and white on a fax machine on the floor, you can barely see the tracing for the background. So thank goodness we got the electrocardiogram. I mean, you can sort of make it out, and we could sort of make an inference about this. But I just want to say again, this was last week. And this is the means of which arguably one of the leading institutions in the country is forced to obtain information from offices around the country because of the way we're configured. Remember what I said before, we're in a digital age, but we're acting still like we are in decades ago with regard to how we think about how this information is organized. There was another woman who came in, she had low blood pressure. The emergency department treated her like she had shock. But the truth is actually, once we finally got her records, it turned out that she lives at a very low blood pressure. And so all of their sort of reaction and emergency commotion, all the ruckus that was generated, all the medications that were administered, were actually not necessary. But they didn't really know exactly who she was. And she, at that moment, all the commotion wasn't able to really convey that clearly. It's so bad that there's a patient that we had that walk in, this patient with a long heart history, and we start talking to them, and it turns out where there's information we need. I got to get going, right? we got the information we need. The person's from Middlesex, and people say, I don't know how we're possibly going to get that information. It would take us all day. said, well, why don't we just drive there for 20 minutes and ask them for the information? So this is a state of what we are. Hospitals, how about hospitals? They're faced with the challenge of this incomplete information, excess testing that has to be done because the information is not available to them. And then they've also got these regulatory requirements. This meaningful use stage 3 is going to may say 25% of your patients need to be engaged with the health records. The hospital set up these portals so that people could have some access to their information, but it doesn't really give them all the complete information, and it doesn't satisfy the meaningful use. And hospitals are faced with situations like, how are we going to force people onto the portals? How are we going to possibly satisfy this? They don't have a way to do this. But it could be that if they just made all people's data available to them immediately when they left the hospital, then they would automatically be satisfying all those regulatory requirements. Plus, they'd be saving all the money that they're currently spending on providing records to people. Researchers, I think I've told you, we face the uphill climb of collecting data from subjects, from people. We should stop thinking about them as subjects. They should be partners. If they actually had their own data, what could the world be like? We could be actually one big team. Large groups of people could coalesce and find researchers. They actually have the data. They can be data donors. They've actually got all the data from different sources. They now are people that need to be wooed, enticed. They need to be partnered with, respected. They need to be brought into the research enterprise in a way that hasn't been traditionally done. And I can go on, but the idea here is more engaged people who possess their health information, more informed clinicians, more patient-centered hospitals and health systems. And I want to say that, so this seemed like a pipe dream, right? I mean, the idea is everybody wins if we can actually put the patients at the center and allow them to be the recipients of their own information and do it in a way that they can use and share. So it's not about just describing problems, but it's trying to figure out whether or not we can solve them. So I've been working with Yale-New Hospital on a startup to try to create a platform that would be entirely patient-centered, that the entire mission here is to promote the interests of patients and not to go around their back, not to use their data in any other way, but to say this is all about them and what they want to do with their data. This is what. So we call this product Hugo. You know, this is your health data going with you. And I just want to quickly say this is a highly secure cloud-based personal health record that will be personally integrated with the electronic health record. Where it departs from what we've done before is that by working with the healthcare system, and Yale-New Health System is a remarkable place, but they also have all the challenges of everywhere else. We solve the problems within the healthcare system, but most importantly, we provide for direct deposit of the information to the people and a system that can sweep every day and continue to deposit so people don't have to do it themselves. And then they can have complete control over it. No one will access it without the permission. They can share it when they want. And so I imagine a day when it's actually the patient who's the repository of all the coherent information about themselves. And it travels with them. And all they have to do is flip a switch. Some people will care to know more. Some people will care less. But wherever they are, they can share it. It's like they do their banking and their financial services. And then I have another idea, which is, you know, one frustration for me about Connecticut is we have such an immense depth of talent in this state, and we always seem to follow. I can rarely see in healthcare where there's something where we truly get out in front and lead the nation. And then what really bothers me is we're between New York and Massachusetts, and they're crowing all the time about their innovations, and Connecticut's just sort of sitting in the middle, and we really fail to really take that leadership. I said, so what if we're able to say we can get all the hospitals on board in Connecticut? And we'd be the first state to say every citizen in the state of Connecticut would have all their data. And whatever hospital you ended up going to in the state of Connecticut, that data would travel with the patient. And every hospital could then, if you wanted to, you could send it to your other hospitals, or if you just needed to, you could send it to them. But this becomes a fully integrated state where every citizen has all of their own healthcare data. Imagine the kind of interest that would attract nationally and internationally to say that that was our commitment in this state, the kind of business opportunities that would start to grow, the kind of people that would come here to try to leverage on top of that data economy. Because now all of a sudden patients have something that's valuable. It's not people going around patients, not behind their back, not selling their stuff, but it's actually the patients themselves who have it. And now we're racing in this state to show how to leverage it, how we can be wise about it, how we can help them do a good job with it. how we don't have to go out and buy Rhode Island's Health Information Exchange for $50 million, which the state legislators are suggesting. But we're actually letting the market take care of this, and we're saying what we're doing is letting the patients lead, and we're going to provide that support on top of it. And so, for me, this idea is about making Connecticut at the center of what will be the future of health information, of medicine as an information science, and putting the patients in the middle of that. So, I think in summary, I would say it's a privilege to be here with you today because I wanted to just share this big idea. I think it's necessary. It'll benefit everyone if we can do it, and it'll change the entire paradigm of the way in which medicine is organized and practiced. So I say, help me with this movement. Change the balance of power. Put people first. Join me in putting the conception of patient to rest. Actually, that whole name, patient, implies to me a certain hierarchy. And let's usher in a notion of people we can engage, empower, and strengthen as partners. We healthcare professionals are not there to impose our values. We're there to help them pursue a course that's consistent with their wishes. This will represent a massive paradigm shift in medicine, and I think it's the right time. Thank you.
While we're getting the screens changed here, my name is Bruce Carlson, and I was asked by the Connecticut Health Council to moderate a panel discussion to pursue the big idea that was just presented, as well as some of the other issues around what happens when we move toward a patient-centered society, patient-centered data society. So let's start with an introduction of the panelists themselves, and we'll go at my far right, your left, and it's Taj Anand. We have Daniel Barchi from the Yale-New Haven hospital system, and Michelle DeBarge, who is a partner with Wigan and Dana. And you all have their biographies at your seat. But I'd like to give each of them an opportunity to just speak for a couple of minutes about who they are and how they're connected to this particular issue. So, Taj?
Well, first of all, thank you for having me here. It's a privilege to be with these panelists and having folks here. They told me nobody would show up. Look at all of you guys. It's awesome. I have a great job. Someone asked me, what do you do, Tej, for a living? And I tell them, I have a really great job where I can't help it if you have to go to the hospital or the doctor's office for a procedure one time. But I want to make sure that once you come home from that procedure or that visit, you don't have to ever go back again. And you can get all the care you need in your home in a way that's satisfying to you, that is personalized to you, that is at a cost that works for all the parties in the system, and that produces outcomes that are the best for you. That's my job. It's a great job.
I'm Daniel Barchi. I'm the Chief Information Officer for the Yale-New Haven Health System, the Yale School of Medicine. It's my privilege to lead the technology teams that provide all of the infrastructure for a lot of the work that happens. So the people in our organization run the informatics systems, run the electronic medical records, run the network and backbone. And that's really important because technology allows us to do a lot of what we need to in healthcare today. But here's the thing, technology itself is not that important. What it enables is really important. And what Harlan said is true. The electrons can be controlled and can flow in any direction. It's really a question of what we do with it. When we talk about healthcare technology, people often want to spend big dollars and buy bright, shiny objects that make things really interesting. But really, most of healthcare technology is about 80% people and about 15% process and only about 5% technology. And the idea that Harlan introduced this morning and that we're partnering with him and the Hugo team on is important because the technology exists. It's really the process of getting data to patients so they can use it in any form that they want. We're really proud to be working with Harlan and with Hugo to make this happen, and looking forward to getting data into patients' hands so they can use it on their own.
Hi, everyone. I'm Michelle DeBarge. I'm with Wigan and Dana. I'm a healthcare regulatory lawyer by training. I've been with Wigan and Dana for about 22 years. And I think of my job, one of the core practice areas of mine is privacy and security, and of course the wide range of healthcare regulatory issues that face healthcare providers and others. But I think of my job as trying to help folks like Yale-New Haven Health, CareCentrix, and others navigate the legal landscape that's often in the way of some of the goals that you have, but it is there. And sometimes I feel terrible that I'm sort of the messenger, but I do try my best to help manage those issues that come up. And I think, personally, I've had experiences like serving on the Legal and Policy Subcommittee of the now defunct Connecticut Health Information Exchange, or I guess we can't really call it defunct. That suggests it was actually functioning. So the project once known as the Connecticut Health Information Exchange.
It was pre-funked.
Pre-funked. There you go. And an advisory committee to the same pre-funked project. And so I've seen sort of the efforts to try to get exchange happening. I've seen the challenges and the impediments. So I bring to the table, more of obviously the legal perspective, and I'm really looking forward to this discussion today. And I think Harlan's idea is just fascinating. I just want to keep saying amen, amen. I mean, I just think it's, it just, as he said, it's a complete paradigm shift. It turns sort of the notions of how we manage and access and share data on its head, and I think it's very fascinating and exciting. I'm looking forward to talking about it more. Right. So thank you.
Thank you.
Well, as you can tell, we have three panelists who can look at this particular issue from kind of very different positions, and I think it will make for a robust discussion. So my role is really to just let them go and speak toward the issue and maybe do a little bit of directing along the way. My first question, I think, for each of the panelists, and then we'll kind of zero in on particular issues, is you heard a little bit from Michelle about kind of her reaction to Harlan's presentation, and I would just be very interested in both from Daniel and Tej's perspective. What's your reaction from your position? So from the CIO of the one of the largest health systems in Connecticut, what do you think? And also from the perspective of a CareCentrix, which is working with 70 million patients. I mean, many patients all over the country. What's your perspective on this sense of the patient-centered data? Tej?
Well, we aspire for 70 million patients. We got about 23 right now.
Still not bad.
So, I really love the way Harlan presented the whole package. And then I love the way you talked about how it's really what piece technology plays in what we do. And, I took some notes while Harlan was speaking, and one of the questions that popped up in my head is, why can't we move from the paper paradigm? Okay. I'm an electrical engineer, and I always believe in taking the path of least resistance. Electrons like to do that. So why can't we move from the paper paradigm? And in my mind, if you just look at technology, usually that's where we hone in. That's where we focus. That's where, the Microsoft Vault, the Google Health, now truly defunct, initiatives focus. They focused on the technology. And if you look at technology, it can, at a very high level, it can do three things. It can get you efficiency, it can get you compliance, and it can get you the basic bookkeeping, the basic tackling, blocking and tackling, as they call it. Technology can also help you with behavioral change. And technology can also change business models. Okay? You see what Amazon has done. You see what Netflix has done. You see what iTunes did. They upended industries. Okay? In the healthcare industry, it has all been about efficiency and compliance. we are now seeing the beginning of behavioral change. And what's important when you look at behavioral change is you have to focus on the individual, but the individual is wearing different hats, or in my case, turbans. And the individual is the physician, the individual is the home health aide, the individual is the nurse, the individual is the pharmacist. Healthcare is a very multidisciplinary field. These individuals have different triggers. The individual is the person going through a certain condition, sometimes for a short period of time, sometimes for a long period of time. That individual has a web of relationships. The spouse, the children, the parents, they all have influence. So you cannot have a behavioral change aspect to technology that ignores that web of connections. Usually I can go to Amazon and buy whatever I want, given if I have the money and my wife says it's okay. But I usually can't. I can't always do that in healthcare. Okay? And then if you look at business models, one of the things we have not changed in healthcare is how we pay for it and where the power lies. Okay? And they used to say, and when I was young, and they say it still now, he who has the gold makes the rules. That's the golden rule. So where does the power lie? And in some sense, unless we address those issues that are very fundamental, we cannot get to the vision. And I don't want to sound pessimistic. Those things can be addressed. And what I like about what Harlan is saying is, if we take a small state like Connecticut, and by the way, it looked a lot bigger in your slide. If we take a small state like Connecticut, where we have a few dominant health systems, we can make them come together, and you could affect change by looking at all the stakeholders involved, because you have to, in some sense, while you're in Connecticut, you have to almost in healthcare always be from Missouri. You have to be the show me state. You have to say, show me, because people don't believe unless you show. So if we can do that experiment and show, it will work. But we have to take all these things into account. And maybe I spoke too much.
No, that was brilliant. That was brilliant. Especially coming from an electrical engineer. I'm very impressed. I got a C in electrical engineering in college, so I'm probably...
We're not going to grades.
I'm probably more qualified to talk about process than the technology itself. And actually, I do believe it is about the technology, like I mentioned before. And I'll tell a different story that shows you how we can use what we have today, and that there was no barriers to making it happen, and then apply it to the big idea that Harlan introduced. We've had an electronic medical record in the Yale-New Haven Health System, the Yale School of Medicine, for years. We didn't have such a good clinical trials system. We had bits and pieces of one, but about 3 or 4 years ago, we installed an integrated clinical trials management system. So 2 different companies, 2 different pieces of software. They both happen to be from Wisconsin, but other than that, they had no relation with one another other than we were their biggest customer in almost both cases. And what we said to them was, gosh, it would really be good if we could share data, because the same patient who's in a cancer trial is also seeing us because she fell down and broke her ankle. And they're not different patients. It's the same person with the same body. And we did some work with them, and it wasn't that much technology. It was more about trust and sharing of data and aligning our resources and a little bit of interfaces. And we've tied these two systems together so they work beautifully for us and for other customers around the country. And here's what's really important to me. If one of our patients who's on an oncology study shows up in one of the emergency departments of the Yale-New Haven Health System, so think about that, a Yale University oncology study, same patient shows up in the emergency department, say at Bridgeport Hospital on a Saturday night with flush red skin, you know what happens? First of all, there's a banner in that EMR that says to the ED physician, you know, this patient's in a study. And there's an automatic link once that patient shows up in the ED that goes through the EMR, across to the clinical trials management system, and out to the care coordinator that sends an email to the care coordinator who might be sitting at home on Saturday night watching Orange is the New Black that says, hey, do you know that Joseph Smith one of your oncology patients just showed up in the ED, or one of your oncology study people showed up in the ED at Bridgeport Hospital. Wow, that's a paradigm shift that never happened. And so in that way, we can do better care. It gets even better. Say that one of the patients in an oncology study passes away, and the Yale-New Haven Health System or one of the physicians who uses EMR in the Yale Medical Group or in the community denotes that that patient is now deceased. That care coordinator for the study gets an email saying, Josephine Smith, the patient in your oncology study, is deceased. From a care coordination point of view and from a patient point of view, what does that mean? Think how many thousands of calls have gone on in the United States every year. Hey, Sally, I'm trying to get in touch with your mother, Josephine. We haven't heard from her in 2 weeks. She was supposed to have shown up for her blood trials. We haven't get in touch with her. What's going on? We can't, what's happening? Those kind of horrible, horrible calls. We're preventing now because we're tying these systems together. And it has very little to do with technology, but it's all about process. In the same way, what Hugo is doing with patient records is very little about technology. I mean, between Amazon and all these other tools, we can do all this stuff. It's really about making data available to patients so they can use it in any way they see fit. And that's why it's so important to us, and that's why we, the Yale-New Haven Health System, have partnered with Harlan and Hugo to make this happen, because we really believe that shifting that balance of power and putting data in the hands of people who can use it is the right thing to do.
So, Michelle, unfortunately, as the attorney in the room, you often are put in a position to maybe lower expectations or at least define obstacles.
That's an interesting way of putting it.
So what are the obstacles? What do you see from taking this big idea? What from the legal side and maybe even from the practical side from your experience? What keeps us from getting there?
Well, I actually think the big idea helps with some of the current impediments. So I guess I'll start there. When we talk about the environment that we're in, we have, as I've already mentioned, the challenges around privacy and security requirements, and it's rooted primarily, the application of those requirements are imposed on the individuals or entities that maintain the data or control the data. And it's restrictive. It's difficult to get information moving around, even if we operate under the premise that the patient can consent to that. We have these laws that have been developed long ago in a paper-based environment, and they're not really equipped to address sort of a real-time query and retrieve kind of notion. And so they're difficult to manage. It's difficult to get those patient consents that you need. For example, if we're talking about the federal drug and alcohol confidentiality regulations, if you've got information that is subject to that, those requirements are very stringent. A patient needs to decide in advance and articulate with specificity who may receive that information. And so you've got to know that in advance. But if the treatment providers are changing over time, how do you manage that in an electronic environment? It just doesn't work. It's not practical. So you have those sort of legal impediments around how you have to manage privacy and security based on the current framework. I think there's also some issues around, this isn't strictly legal, but I see it, patient trust. So even with this notion of the big idea where, the patient will have more control over and access to their data, I see it with the patient portals, even though they get more limited information, where individuals are afraid. They're afraid to agree to have their information or to keep their information in an electronic environment. We are bombarded every day by information about massive breaches, and I think people are concerned. So I think one of the challenges, it's not strictly legal, but will be getting people to believe and trust and understand that using the information in this way is trustworthy and that people actually do it. Because as we know that, the interest in patient portal use is not as high as I think folks wanted it to be. And anecdotally, I've heard individuals say, well, yeah, my provider gave me this authorization to, sign me up and sign my kids up. And then I went online and I actually read the agreement, and it says once my information is transferred to the PHR vendor, they're not subject to HIPAA, they don't have to do this or that. It's like, whoa, wait a minute, I'm not going to agree to this. And so you have folks who are sort of inclined, and then they read this information and everybody's kind of scared. So I think that will be one of the challenges I can see in terms of educating and getting people to trust and buy into that, even if we set it up for them and make it available.
I'll just respond to that too. I think, this is where I think the differentiator needs to be that, is whoever's doing this worthy of the patient? And being worthy means that you've articulated principles of interactions it's not just, it is true, it's out of HIPAA because you're handing it to people. And I think there needs to be a commitment about that, nothing's going to be done behind people's backs. Everything's going to be done with them and with their permission. And with regard to the security worthiness, I think you have to get to financial services level, security. And by the way, there's probably nothing that's not hackable somewhere. So people have to decide if they want to be able to use electronic data, no matter what it is, that there's going to be some finite risk. But what you want to do is try to create it so the risk is really small. And, many of us are comfortable doing online banking. We feel comfortable in that environment. We know that there's not a zero risk. There's a small risk. We do it because it helps us manage our lives. I think we'll need to get that. But, you're going to have all these layers of encryption and so forth up and down the line. People are going to need to be able to demonstrate that, prove it, without challenging people to break it, by making guarantees that, this will never be hacked, because that'll just attract a lot of people to, prove that what they can do, but to basically try to be worthy of that responsibility. I believe it can be done. And I think that, the reason you're hearing about all these hacks in large part is because, and Daniel can comment on this, these systems were not built to defend. They were built to transact. So when Yale-New Hospital begins to buy their electronic health records, they were one of the earliest adopters in systems, and when they start pulling together legacy systems from all different places, they were not fundamentally thinking this is a defense. They're fundamentally thinking we're buying a new product. And each one has to satisfy certain requirements. I think we're in a different era. A new company that comes up today, their responsibility is to think our primary goal is defense. Our entire system has to be built from ground up, defense. It also has to transact, be consumer friendly, everyone has to be able to use it, but it's being built for defense. And that's different than, I think, what Sony was thinking, UCLA Health. I guarantee you there's no one there who thought, they're thinking how do we defend a system, but they're defending a system that's got leaks everywhere, because it wasn't built from the ground up to be configured like that. So with all these legacy systems, there are a million ways to get into any health system's place because they weren't built like that. Now they're trying to retrofit back and they're trying to build that defense, but I think for a new company, that's where you build it from the ground up. And that company's got to be worthy of the trust, and no matter who it is. And you're absolutely right. You've got to be able to convince, you've got to be trustworthy. And I think the secret to being trustworthy is being trustworthy. Right?
That makes a lot of sense.
And that's what you've got to do.
Can I make one other comment? This may be somewhat cynical, but I sort of over time in my experience, everything seems to follow the money. And I'm thinking, you talked about how, we have various commercial interests and those who control the data can, maximize economic opportunities because they control it. Well, once the patients have that opportunity, they may be more motivated, right? I may take my risk here and put my information, in this platform, but I have some countervailing interests, so I'm willing to take that risk if I have some economic interest, and I think that together can motivate people to use these mechanisms if they have other interests, not just treatment interests, which is clearly important, but other economic interests. If that evolves, that may compel folks to want to take advantage of this as well.
It's interesting you raised the question of the money. Both you and Harlan raised really challenging points for us as a health system. We need to protect the data, and then there's expenses to all this. My colleague, John Hlemke, who's the CIO of Beth Israel Deaconess up in Boston, says we in healthcare have this problem. We have to protect, now share, right? It has to be secure all the time, 100%. But then if somebody needs it, we have to be able to instantly produce it and share it with somebody who we might not know very well. So it's this dynamic of trying to keep it safe and protecting it at the same time. So there's that whole issue. And then Michelle brought up the question of money. And it's interesting because it's Harlan who came up with the idea of working with a large health system and getting to share patient records in a more dynamic way. But wouldn't you know, it's also more cost effective. And I never knew this until we started working on this project and we started working through the health information management side of our health system. But we have more than 20 people, and we spend more than several $1 million every year producing data for patients. So think, every time you need a copy of your medical record, or your friend moves to Arizona, or an attorney needs a copy of a medical record, they contact our health system's health information management team, who has a team of more than 20 people and spends several $1 million digging up this data, photocopying it, putting it on disk, faxing it, doing all this stuff. And it actually would be a lot more efficient and less costly if we have most of this data electronically already, if we're just sharing it in a more free-form way, in a secure way. So there are ways both to meet better needs, share data better, and to be more cost-efficient as well.
Tej, in the, from CareCentrix, you have a lot of data for all of those patients. How do you protect that data?
So we protect it in various ways. So first of all, we are beholden on that for that data from the entities we get that data from. So there is a basic protection in place in the agreement we sign with those entities. We call that a business associate agreement. That agreement stipulates how we will save the data. So it kind of, that's the non-technical stuff. From a technical point of view, there are various methods that we use throughout the company and throughout all of the people that get access to the data. And I'll sound a little electrical engineering, so bear with me. So first, and Harlan talked about the various layers of encryption. So one of the things that we have to do is encrypt the data at rest. So data at rest means when the data is stored and it's sitting there, like we're sitting on our chairs, we are encrypted. So if somebody were to get access to that data, it would mean nothing to them. They would not be able to get at them. So that's data that's encrypted at rest. Okay. Then you take it a step higher. Data has to move. So we're sharing the data, and the only way data can move is through bits and bytes in various electronic channels going from here to there. Right? Simple. So when data moves, so data at rest, data in transition, it has to be encrypted again. Okay? So that's it's the second level of protection. Now the third level of protection is who has access. So that is simple. Who has the password? How was that password obtained? How was that password maintained? What are the rules around the password? So those are all the rules around access. Here you come into the fact that you don't want to have someone just say, okay, I am Tej, here is my password. There has to be a verification. Are you Tej? Well, you were Tej then, but are you still Tej? Okay? And that's where all of the multi-factor authentication mechanisms come into place. So now we've handled data at rest, we've handled data in movement, we've handled access. The next part is authorization. Now you might have access to the system, but are you authorized to do something with that system, and what is it that you're authorized to do? And that's where you use the HIPAA provision of minimum necessary. So what are you accessing the system for? What is your job? What do you need this for? And is what you're being shown, is what you're being authorized for, minimum necessary for you to do that job? So if you put all of these protections in place, okay, you have laid the foundation of a secure system. But you're not done yet. Okay, now you have to think of all the bad people. And I don't know why, but we always think of them as outside the US. But that's not always the case. Okay, these bad people are trying to get into your systems. So you have to now think like them. What is it that they would do to get into your systems? And you have to be constantly vigilant that you are monitoring against that. You have people that you pay to be bad, and they're constantly trying to get into your system, even though you're paying them to be bad so we can find out our holes. So that's what we call our intrusion detection, our monitoring, all of that stuff. That's where the virus checking comes in, things like that. Now, all of this only gets you to react to the problem after you find it. Okay? So there's always will be a new problem that nobody thought of, but the smart person sitting somewhere in the world thought of, and boy, they can get rich for a little while before they're caught. Okay? In jail. So you got to constantly be thinking of that. So that what you do with that is you take all your infrastructure and you identify what all the good guys are, and make sure only they can come in. So once you surround, so you build the infrastructure, then you surround it with all of this protection. It'll be pretty hard to break it. Even though anything can be broken into, it gets hard.
Great. So you have a good sense of who the panelists are and where they're coming from. Clearly, we've all been stimulated by Harlan's big idea. And what I'd love to do is open up the questions to anybody from the audience that would like to ask a question to anyone here in the panel. Yes, sir. Can I remind you that you need to hit the green, yeah, and hold it. I think you have to hold it while you're talking. There you go.
I love the idea, but I think we're such a long way away from that until we get an integrated healthcare system. For example, it seems Harlan's idea is too much focused from the hospital's point of view. Luckily, in my case, my physician, his practice was purchased by Yale-New Haven system, so I'm integrated. But if I went to get home health care, if I went to get ambulatory surgery, if I went to a nursing home to get care, if I went to a psychiatrist who is not part of this, it seems like it's going to be very, very difficult to, in the short term, to move to what Harlan is suggesting.
Mm-hmm. Response?
Yeah, so thank you. I think it would be such a sea change to actually be able to get started and get people to funnel in their records. A lot of their high consequence information is within hospitals and health systems right now. A lot of individual practices are there. The notion is you've got to start somewhere. I mean, we're already talking also to large other purveyors of data, Quest, CVS, Walgreens, other groups, and bringing in data. We'll certainly want to talk to CareCentrix and others. I mean, the idea is showing proof of concept and that this can work. You can actually stream data in for the benefit of individual patients, and then trying to bring other groups on board that'll say, hey, we want to be part of that team. We want to demonstrate our commitment to individuals. But you're correct in identifying, I've heard this a lot, why not start with physician offices? Why not start here? Why not start there? I think it's because there's a business model to start with the health systems who have at stake a lot of money in both providing records and fulfilling regulatory requirements. And it's about trying to provide some momentum to the idea that this is possible. Once you have the platform, I think what you want to do is begin to start finding all the ways in. We're not going to be at a single-payer integrated system for any foreseeable future. We've got to find solutions that are based on the system we have. And I think this can be sort of an undeniable sort of juggernaut if we can begin to put people in a position where they can get their data and use it. So that's the premise, but it's a reasonable point.
And by the way, I will definitely, agree to explore this where people that are getting discharged from any of the health systems that are connected to Hugo, and if they're coming to us, we will share that data because we ourselves can benefit tremendously by having that discharge data, because that then helps us plan their care at home in a personalized manner. And, it just kind of
he's got such, I've had the opportunity to talk about the kind of things he's thinking about in CareCentrix, and this is exactly the point. The information people hold, they can share easily to CareCentrix, easier than Yale-New Haven Hospital getting all these authorizations. They can provide better services, and they're showing their willingness, hey, we want to be part of this, and we want to reciprocate. We want to give you back the information from us, so when you go see your doctor, if there are any questions about what's going on with this caregiver, my usual approach is someone comes in, I don't even know they've seen CareCentrix. I mean, I'm not aware of them at all. And yet important transactions and information's passing back and forth between, no, not because of you, but I mean,
please be aware.
You're a lovely person. And that's a great company, I'm sure, but I'm just saying, we as doctors aren't aware of any of the home health issues that are going on because it's sort of out of our radar. And as a result, there's important information and transactions and experience that we can't incorporate. We could spend an hour with a patient trying to understand it, but they may not know all that information. But if it's sitting in one place where it's residing, we can use that as a means to move back and forth.
Yes, sir.
Thank you. John DeStefano, the former CTO of the, as Daniel put it, the pre-funked Health Information Exchange of Connecticut. So I applaud your idea. I think it's a great idea. Many of the problems we had with the exchange to start with were not technology, because, as you said, technology is a very small part of this. But we're very political in nature. So, in Connecticut, I sort of get the idea that if it's not my idea, it's not a good idea. So I'm wondering how you're going to form this coalition to get the hospitals, to start with, which I think is a really good starting place. They have the technology in place to be able to do this. What do you have in mind as far as how you'll engage, the various hospitals and larger organizations around Connecticut to to actually send you data.
Well, so let me just be clear. They're not going to send me data or Hugo data. They're going to be giving people back their data, and we're providing a platform for that to happen. And the idea is to engage people with a combination of their self-interest and their commitment to their mission, which usually has altruistic and patient promotional pieces to it. So you're basically trying to tell people, when I talk to hospitals, they're saying, this is a good deal for you. And it also puts you on the good guy side. When I've been talking on the government side, people are going like, wow, you mean we don't have to pay all this money to build this health exchange, and we don't have to sustain all this outside criticism and actually run the system and be accountable for the kind of service it's providing as a consumer product, where if you go to Rhode Island, for example, it's actually very difficult to use as a consumer product, even though it has some features to it. You go to, I mean, you hear from people like Taj and saying like, wow, we would love to be able to do this. There's not a person who doesn't win in this system. What you try to do is to have people see like this common self-interest as well as this common dedication to mission. What I want to see is Connecticut, everyone to have a sort of stake in saying like, I'm tired of Connecticut following. I'm tired of Connecticut being last. I want to see something amazing happening in Connecticut. And I believe if we can create this sort of health information infrastructure that's built on a market and is giving patients the power, then it can build jobs and companies and will attract investment. It will bring that next generation information economy to Connecticut in a way that you will not see anywhere else. And we've got a tight enough bond of 30-some hospitals, a healthcare system, and extraordinary talent in the state that it could then be the basis and foundation for amazing things to follow. But I think you've got to go one by one and talk it through with people. But the amazing thing about this so far, I mean, it makes me almost a little concerned. Everybody gets excited about this idea, and everyone can reflect on their own personal experience where this would have been useful, and everybody thinks, wow, this would be great to make happen. And then working with a partner like Daniel and the Yale-New Health System means, you sit there and go, this would be impossible to do. And then you say, well, look, we're in a big system, and they are committed, and we're working together as teams, and we're overcoming each one of those challenges. If you build this outside and then try to sell to a health system, I can tell you after our experience working inside, it's dead in the water. You can't do it. You need to understand exactly what they're dealing with every day in order to build something that actually can go. We've got a second healthcare system, a $4 billion healthcare system with 7 hospitals. We're talking to is doing a second proof of concept in another state. But my real dream is to make Connecticut great. Like make Connecticut the place where everyone's going like, wow, they did. And that's where people come here as the laboratory to figure out how to leverage next. And then it goes, it becomes the standard for the entire country.
I do want to add one thing here. Maybe Daniel and I overstated that technology is, not that important. And I just got a little vulnerable there, Chief Technology Officer. I got So technology is actually very important, and it gets noticed when it doesn't work.
Right.
So how often do you go home, turn the light on, and say, thank you, Edison? But how often do you turn the light on, it doesn't come on, you go, oh, that damn power company, right? And when technology doesn't work, like it did not with the healthcare.gov site, okay, that was a technology problem. So there are inherently technology problems. So technology is necessary, but not sufficient. Is kind of the way I would put it. I didn't want to, say.
Can I make one comment, and then I have a question for Harlan, if you don't mind. I just wanted to comment on the issue about getting others to participate in this process, and I'm glad you made the point about the patients will have the data. I mean, just to underline the fact that the law does support a patient's right to get access to their data, so in that respect, it's helpful.
30 days after, in a format that the lab, I'm so sorry, Michelle.
Well, that's true. There are some limitations and there are some exceptions. But generally speaking, there is that right. So at least there's something to work with in terms of getting the data into the hands of the patient and not having, providers completely being able to stonewall that in some respects. But I had a question because I wanted to understand once you set this up, and if you want other providers to participate in working with the patient, right, to say, I want your data, please send it to me. What is it that those providers are going to have to do to be able to access that? What technological features or process features will they need to have in place in order to be able to do that?
Yeah, I think that there are two ways I envision that happens and that we're working on. One way is that there's a viewer. So anybody would be, if I gave you permission as a healthcare professional, you can have your own, way of viewing that person's data who's given you the permission to. What my preference in the long run, even the shorter run, we're doing this at Yale, is that actually you can import it into the EHR. Now, the first step is a lot of the health systems, including Yale, says, I don't know if we can trust data from somewhere else. Okay. Middlesex Hospital or, but Hartford Hospital? I'll say definitely not Hartford. Yeah. But, we've got this thing where people can't trust. That's fine. So there'll be a place in the EHR that's sort of for what they call media, sort of for files that are coming from elsewhere. People can store them, unfortunately unstructured probably, and non-computable. But how long will it take us to get to the point where we say, you know what, if this comes from a group that we trust, all the hospitals in Connecticut, we're going to find ways to create the applied program interfaces, the APIs, the pipes, that actually can populate some of our stuff. We may tag it, this was from somewhere else, but that'll increasingly become integrated so that, again, you don't lose the structured and computable nature of it. My idea is that then, if I say, my doctors are at Yale, wherever I go, I'm going to hit the automatic transfer to Yale button. So actually, I don't even have to worry about it. It just means if I end up anywhere else, do anything else, I want it to flow there. If I'm seen by any pharmacy, I want that data to go. And then it's up to, we need to work with Daniel and others, say so how do your doctors and how does your system ready to do with it? It may take a little while. Some of it you may put in the unstructured areas. Some of it you may bring in earlier, like lab tests, to say CLIA standards. I think we can bring in lab tests from anywhere. But other stuff we may not. This is all to be worked out. That's why, again, I think it's exciting to say we start bringing more people together. We figure, what are our goals? Our goals are, no matter where you are in the state, your data can be made available immediately to the person who is trying to help you with your health. I'd like to make it so if you're unconscious, you could, with your permission, have said in advance, if I'm unconscious and I'm in a certified emergency department, you can make my stuff available. That there will be options like that, but all to be worked out. And yeah, we're at the beginning. We're in the first half of the first inning here, right? But I think that this is an idea that could grow quickly and that we'll learn with experience from as we go. And my main thing is it's got to be secure, and then people have to have control. No one's going around your back. We're going to honor your agency over your own data. And then from that, we see where we go.
Daniel, do you have anything to add to that from the health system perspective?
No, Harlan said it really well. We need to learn how both to get the data out so the patients can use it and choose where they want to take it. And then it actually is almost more difficult deciding what to take in because it'll be driven both by physicians and what they want to see, how our EMR represents the data, how we make sure that it's updated. So these are questions that are worth working through over time. But the most important thing is the idea that patients own their data. We are caretakers of it, but we want to make sure that they have control over what they have.
Great. I think we have time for one more question. Yes?
So I'm interested, my name's Ira Reynolds.
Are you pressing the button?
Oh, sorry. The owner of Ira Reynolds Consulting, and it's a data processing and digital preservation company. I'm interested, even though you're in the early stages of Hugo, what's the role potentially of the quantitative self, the quantified self? I think about companies like Fitbit, which in less than 10 years helped to create a $6 billion industry, and they're now going public. So have you thought about how the patient actually is taking control of their own wellness and looking at early adopters? What's the role of potential early adopters in their wellness, people who are using wearables, and the role of your new startup?
Yeah, thanks. It's a great question. So my vision about this is that there are people at various different stages of how they want to interact with their health information. There's some people who are saying, I just want to use it as an insurance policy. I actually don't want to engage. I'm too busy, not interested, or I feel like I can't for whatever reason. And that it's just there for them to use it when they want, or they're using it to share with their family. There are an increasingly number of people who actually want to be fully engaged with their health. Mm-hmm. And I think the idea here is now, this is a platform that they own, and that they can run, and that's fully equipped to be able to stream in information. And it can be from wearables. I can imagine there's some people who would be filling out questionnaires periodically. People with chronic disease who are sort of saying what their symptom patterns are like, helping give us insight into their function, their experience, their lives, and then being able to provide visualizations of that so when they go see their doctor, immediately they can see things about them and on their initial dashboard that are not just their blood pressure and pulse and weight, but actually information that's streaming, and even you could imagine for some patients who are in fragile conditions being updated over time and being monitored in ways that through advanced algorithms are telling you, hey, probably should call that person because of the way that this is going. And the way that it's going on the other side is people are developing consumer-oriented platforms for people to stream their wearables, but it's completely divorced from all their high-grade clinical or medical information. My idea is to build it the other way, which is you build this foundation that's interacting with anyone who wants to do anything medically, and then you've got on top of that your ability to stream in this information and advanced analytics, which may combine information from your healthcare as well as from your wearables. And again, up to you. You're sharing or not sharing depending on your own preference, but that functionality, it would seem to me, would be an important part of this. And I think the very best care and outcomes in the future are going to be a hybrid. You know, medical care systems expert in medical stuff. People are experts in themselves. And we're able to then create ways to systematically collect information about their experience that's relevant to their health in ways that they can be partnered with people in the healthcare system, either health educators or nurses, nurse practitioners, doctors, whatever level that's helping them achieve their goals. Physical therapists, whatever. I mean, all this stuff comes together and then be able to do. But I see people streaming in a lot of their stuff. And we're increasingly using these patient-reported outcome measures where we're asking people questions and it's being organized in ways. Now, it's going to be up to us not to drown people in all this information, but to provide it in ways that are simple, understandable, while the back end's got all the depth and richness, but not make people feel like, oh my gosh, this is just too much.
And you know, I know that's a great question, and I feel that the wearables are making a dent in the behavioral aspects of what technology can do. And I just share with what we're doing at CareCentrix. So at CareCentrix, we are putting the patient at the center. We are letting the patient invite who they want their information shared with. So if they have a home health aide coming home, if they have a nurse coming home, if they have someone coming home delivering a CPAP machine, we're putting the patient in the center and saying, who do you want to share your information with? Do you want to share it with a caregiver? And then we're making that all available to the people they are choosing to share with. We're also letting them share all of their devices. They could have a CPAP machine at home, which is actually collecting a lot of useful data. We want all of that coming into the same hub. We want that electronic scale. We want their, and you know, there's a standard called Secure Direct that you can leverage where all of these devices are not compliant to that standard. So now you can bring all of this together, but the important part is what Harlan was saying is you can pretty soon drown in all this data. You know, I like to tell the story about how I go to the doctor's office and they take my weight and I ask them, well, how am I doing? They said, we don't know. I can't see the last weight. So anyway, so I go, you know, whatever. So why did I get there? Okay, so for us not to drown in data, we have to have analytics and we have to have presentations. So sometimes the analytics are so complex that they don't drive presentations that are understandable. So I always like to marry two words. The analytics have to be such that what they produce is credible. So credible is the word. And how it's presented has to be compelling. So you have to always have a combination of credible and compelling when you're dealing with data. And when you get there, that's when you get to action and behavior change.
And I just, to emphasize what he's saying, it's not just the consumer product, but internal devices, defibrillators, and all these other devices are generating data. Right now, again, they're outside of the entire system. They're not being curated, managed, analyzed in ways that would be helpful. So that's the Internet of Things in medicine is what all needs to come together.
And we're trying to coin the Internet of right things.
So I'm going to invite Oz to come down and close us out. But while he's coming down, may I just join me in applause and thank the panel.
Tej, thank you. Just briefly to come back to Amy Cunningham's earlier remarks, thank you for Bruce and Harlan and everyone for a great presentation. I think we've called your attention to our website. Our next event will be, program will be probably in the Hartford area. We're working with Hartford Health Care right now on an event in September. Call your attention to Jackson Labs Forum, the second one they're doing, in the whole focus on bioscience, which is on October 15th and 16th up at their center in Farmington. And for those of you who are currently founding partners, we'll have our annual celebration on November 23rd. Those of you not affiliated, this is your first program with the Health Council, I'll go back to something about $6 billion IPOs and the point that Harlan has stressed in the beginning. The Council is here to demonstrate the asset base, the significant asset base that is in Connecticut, and how we can leverage it more effectively by working together to ensure that Connecticut, as Harlan has said, is a leader and not a follower. We believe we have the capacity to do that, and we have the capacity to take this significant asset base and leverage it for employment growth at a time when this state has stagnated, and to leverage it for additional capital investment in the state, private capital investment. So that is what we're about. If you want more information from any of us, there are several of us here. Nancy Wheeler's over there. Amy Cunningham is down here. Be happy to talk to any of you about the council. This kind of a program is what we think starts to drive that kind of collaboration and keeps moving the state forward in that real big way that Harlan put it in the map. I always like it when they blow the state up in the way that it's supposed to be, even when the screen goes up. So thank you all very much for being here. We appreciate CareCentrix's sponsorship.
I just want to say one thing. So we have a fledgling website, hugophr.com, and at the bottom, if you want to put your name or email, we'll keep you posted about our progress and let you know what's happening. It's just hugophr.com.
Thank you all very much.
Self-promotional moment.
Exactly.
Awesome. Thank you. Nice working with you.
Good. Well, we should work together. That's great. Yeah, that would be great. Yeah. I just stand. You want everybody to go to their